This program is a presentation of UCTV for educational and non-commercial use only.
So I'm going to be talking about understanding heart failure, causes, treatments, and innovative new strategies for living well. So today, I hope you get out of this presentation to understand the diagnosis of heart failure, what it is, to understand the risk factors for the development of heart failure, to be familiar with the levels and severity of heart failure, different stages, and the different classification of symptoms of heart failure. And then I'll go over treatments for heart failure. That includes lifestyle modifications, the benefits of a clinic, a dedicated heart failure clinic in the management of especially patients with advanced heart failure, medical therapies, surgical therapies, and new devices to treat heart failure, as well as a discussion a little bit about heart transplantation and the indications for heart transplant. And then we'll leave time for questions and answers at the end. So here's a slide. I like this slide because it gives a depiction of heart failure all in one. So this, as you can see, is a picture of a very dilated heart. This is the pulmonary artery. This is the aorta here. It's a big, baggy, dilated heart, puffed out cheeks, kind of looks fatigued, and there's some sweat pouring down, and this person is you can see the breath here from shortness of breath. Okay, just to give you an idea of the scope of this problem, heart failure is one of the fastest growing conditions in the United States. Part of the reason, if not a large part of the reason, is because patients are living longer. They're surviving heart attacks now, so we have better treatment for myocardial infarctions. People don't die from the heart attacks, and now they live on to develop heart failure. To put it in perspective, there are more hospitalizations for heart failure than for all of the cancers combined. That's over 1.1 million hospitalizations per year right now. And there are about 550,000 new cases of heart failure per year. And the prevalence is about 5.7 million as of the latest data from last year, 2009. It is a disease that tends to progress or develop more as people age, so that the prevalence is about 2% in patients who are between the ages of 40 and 59 years, and the prevalence increases progressively as you get to an older and older population, to where there are about 10% of patients who are 70 years and older who have heart failure. So the cost of heart failure, the most up-to-date data that we have is that it cost $37 billion last year. 60% of that money is spent on hospitalizations for heart failure, and the rest, 40%, on outpatient costs. That includes medications, devices, surgeries, etc. And this cost represents an increase of 171% between 1979 and 2009. So here is a curve showing the discharges for heart failure in women and men. And as you can see over time, this is 1979 through 2006 here. And as you can see, the discharges for hospitalizations in both women and men have been increasing progressively. This is about 1.1 million patients here. The women tend to have a slightly higher discharge rate or admission rate for heart failure than men. They also have slightly worse survival. I should say just survival after heart attacks is worse. Heart failure survival is pretty similar. So one of the reasons I said for the rising admissions for heart failure is because of better survival with myocardial infarctions, but the other important cause is due to noncompliance with medical therapy and to dietary changes. So patients are usually advised to follow a low sodium diet, and this can be difficult for patients. There's non-adherence to diet and drugs and non-adherence to following up with clinic visits. There's also the inevitable progression of the disease that leads to heart failure admission rates. And then we do now have guidelines for the treatment of heart failure, and I think that's somewhat slow to be taken up or adopted by all physicians. So there may be a lack of adherence to the guidelines that could contribute to this. And then another significant cause is because patients who are admitted to the hospital sometimes actually have inefficient, or they're discharged a little bit early. They may still have extra fluid on board, and then they go home, maybe to go back from intravenous diuretics to oral diuretics, and then they may have this cycle where the oral diuretics may not be absorbed very well, and then they start accumulating fluid and then end up back in the hospital. So incomplete treatment may be another reason. So this slide shows you that the 5-year mortality of heart failure is up to 50% per year in some patients. The causes of death are frequently pump failure, so weakened heart, just progressive heart failure, or sudden death. And so this shows you the severity of heart failure and how it relates to the modes or causes of death. And so we'll go over the New York Heart Association functional classes, but functional class 2 is better, let's say less severe than functional class 4. And so as you can see here, this lighter blue represents sudden death, and the darker blue here represents progressive heart failure. And then there are other causes here, 24%. So you can see the trend where patients who have functional class 2 symptoms, less severe symptoms, actually have a higher percentage of deaths due to sudden cardiac death, whereas patients with more severe advanced heart failure tend to die more of progressive heart failure. Now, it's interesting, but you should keep in mind that more people die from functional class 4, so that's just the percentage. So there are many fewer patients dying in functional class 2 than functional class 4, but basically the point is that there are significant deaths related to heart failure, and this is the heart failure patient with his head in a guillotine and being asked, by somebody, do they want paper or plastic? So basically, it doesn't really matter whether you die of sudden death, heart failure. It's all not a good option, right? So what is heart failure? What's the definition? Well, heart failure is defined as a complex clinical syndrome that results from a disorder that affects the heart so that it leads to an inadequate perfusion or blood flow to organs. So you have inadequate blood flow to the organs in order to meet the metabolic demands of the body. And heart failure it usually comes in 2 different types. Either we have systolic heart failure or diastolic heart failure. So systolic, let me go through this slide with you first. This is a normal heart, relatively small, normal wall thickness. And this is a heart that has a normal chamber volume or reduced chamber volume, but the walls are thick. And this patient would have a normal pumping function, their squeeze or contractility, or what we call ejection fraction, which I'll get to in a minute, is normal. But the problem is that it's stiff and it doesn't relax well enough, and so it doesn't fill with blood adequately. So patients with this kind of diastolic heart failure, is what we call it, have problems filling the heart. And then you have systolic heart failure, where the heart dilates and the walls are often thinned, but the heart is big and baggy and the heart is weak. So it's a pumping problem. The heart is weak and it doesn't pump adequately, and we call this systolic heart failure. So here's the donkey analogy, where you have ventricular dysfunction in heart failure that limits the patient's ability to perform routine activities of daily living. So this is basically, this donkey is representing a heart that's failed, and the cart with the weights on it represents our body. So the donkey's having a lot of difficulty pulling the cart with the weights. So this slide lists the causes of heart failure and chronic heart failure. So we have systolic heart, dysfunction, or weak heart that's dilated, and we have diastolic dysfunction, that's the thick, stiff heart that has difficulty filling with blood. And the causes of, oftentimes the typical causes of systolic heart failure are here: coronary artery disease causing heart attacks, leads to damage and remodeling, what we call remodeling dilation. There's idiopathic, meaning no underlying identifiable cause. Then there's familial. We understand that quite a few patients who are otherwise felt to have idiopathic dilated cardiomyopathy actually have a genetic mutation in their families, so it's actually familial. And then certain heart valve disorders can lead to dilation and heart failure. Those are usually what we call leaky valves or regurgitant valves, like the mitral and tricuspid valve can lead to heart failure, or the aortic valve can be leaky. So that leads to volume overload on the left side of the heart that progressively dilates and then fails eventually. Hypertension is another cause, and this is usually it's somebody who's had severe untreated systemic hypertension that over time it initially starts with a thick and diastolic problem, but then over time it can dilate and then develop a big baggy weak heart. And then other causes include inflammation. Myocarditis can be caused from viral infections, or rarely bacterial infections or other organisms. There are drug-induced causes like cocaine, methamphetamines, and then chemotherapy-induced heart failure can occur, cardiomyopathy, what we call it. And then the other form, the diastolic dysfunction, common causes of that thickened, stiff heart are systemic hypertension, fibrosis, which can be caused by a number of different disease processes, autoimmune diseases, and there are some other more rare diseases. Ischemia is sort of something that occurs because of coronary artery disease, where the heart muscle isn't getting enough blood flow, but maybe it hasn't had a heart attack yet, but it's chronically having inadequate perfusion to the heart muscle itself, so it can become stiff. And then aging can, over time, our hearts age, and the relaxation function of the heart decreases, although it is not very common to have severe heart failure related to, with diastolic heart failure related to just simple aging. Then there are other diseases that are primary cardiomyopathies that cause abnormally thickened heart. The hypertrophic cardiomyopathy is often a genetic disease that leads to, that's caused by a mutation in one of the contractile elements in the cardiomyocytes, the heart muscle cells themselves. And there are other restrictive, sort of infiltrative diseases like amyloidosis or sarcoidosis you may or may not have heard about. Valvular heart disease, usually the stenotic valves, the tight valves like aortic valve stenosis, where the left side of the heart is pumping against this stiff aortic valve, and it actually, just like systemic hypertension, since it's just contracting all the time and has an increased resistance against which it's pumping, it actually hypertrophies or the walls thicken. And then there's pericardial disease, that is disease of the sac surrounding the heart that leads to a non-compliant chamber around the heart, and those patients will have diastolic heart failure. Normal systolic function of the heart, but abnormal increased stiffness and pressures. So who gets heart failure? Well, you may find it interesting to know that it affects men and women equally. The mortality risk between men and women is roughly equal, similar. Women with heart disease or heart failure tend to be older than men who develop heart failure, and women with heart failure more often have high blood pressure as the etiology of their heart failure. So they more often have diastolic heart failure compared with men, who more often have a history of heart attacks, coronary artery disease, and oftentimes they get more dilated and a weak heart. These are the symptoms of heart failure. Number one would be shortness of breath. So the patient exercises and develops shortness of breath. Fatigue is a huge symptom, especially in more advanced heart failure. A cough with frothy sputum, especially at night, is a sign of pulmonary edema, congestion in the lungs because of the heart failure. Because of swelling of the legs, the feet can become, and ankles and legs can become what we call edematous. And when patients go to bed at night, if they have significant heart failure, there's congestion that builds up at night, and they have trouble breathing at night, and may have to prop up their pillows to get comfortable. And a sign of what we call right-sided heart failure, where the congestion is building up in the legs. It also can, the fluid can build up in the liver and also the abdominal cavity, so the abdomen can swell. And then also at night, when patients are laying down, blood flow to the heart and the kidneys increases, and there may be more frequent urination, although I wouldn't call that a sign of heart failure if you only had increased frequency of urination at night. But, and then if you have really advanced heart failure with very poor perfusion, what we call low cardiac output state, meaning really inadequate blood flow to the brain, you can have memory problems and confusion. So how's heart failure diagnosed? Well, it starts off with a complete history and physical, by taking the symptoms like we mentioned, and also doing a physical exam. We can find evidence of what we call volume overload or congestion on exam, and then the cardiac exam is important. There are certain sounds that we can listen for. And then there are some other tests, and the tests that are helpful are a chest x-ray. We can oftentimes see an enlarged heart on the chest x-ray that will help us. If the heart has high pressure from fluid retention and what we call pulmonary edema, it can leak out. You can see the vessels in the lungs dilate because of that. You can even see little fluid pleural effusions, what we call it, in the bases of the lung cavities. And then there are blood tests that we use to screen for heart failure. A BNP level is one that we use frequently. It's a hormone that's elevated in the presence of heart failure. And then the electrocardiogram can be helpful, and usually patients with advanced heart failure have abnormal electrocardiograms, and there are different patterns for different types of cardiac diseases. Ultrasound of the heart, or echocardiography, or just echo, is the most common screening tool for cardiomyopathy or structural heart disease. It complements the physical exam and the history and physical, and usually confirms that there is or isn't evidence of heart disease. And then in certain patients who have a high likelihood based on history, physical, and some other tests, if they have a high likelihood of having blockages in the coronary arteries, coronary artery disease, then a coronary angiogram may be ordered, where they actually go in with a catheter and inject dye into the coronary arteries to look directly for blockages. So a key indicator for systolic heart failure versus diastolic, distinguishing between the two, is really the ejection fraction. And the ejection fraction is basically the percentage of blood that is ejected per beat at a given starting volume. Let's put it a different way. It's stroke volume, so the volume of blood that's ejected with each beat divided by the volume that it started with. So the normal ejection fraction is over 55%. It's between 55 and 75, usually 65%. So with heart failure on exam and symptoms of heart failure and an ejection fraction of greater than 55%, that person is deemed to have diastolic heart failure. Those with symptoms and signs of heart failure, the syndrome of heart failure, but with ejection fractions lower than that, usually lower than 40%, are deemed to have systolic heart failure. So how do we identify the ejection fraction? How do we calculate the ejection fraction? The most common tool that we use for the calculation of ejection fraction is the echocardiogram, the cardiac ultrasound. Other tests that we can use include a cardiac MRI, magnetic resonance imaging, or sometimes it's not used so often these days, but a MUGA scan, which is basically a nuclear tagged red blood cell scan that can be used to calculate the ejection fraction. So that ejection fraction is important. I'll get to that in a moment, but basically, if you have heart failure, you are at risk for sudden cardiac death. It's sudden cardiac arrest. And what is sudden cardiac arrest? It is when the heart suddenly goes into this rapid and chaotic rhythm to the point where the heart just doesn't pump blood. This doesn't usually cause, it is not usually caused from an abnormal fast rhythm coming from the upper chamber of the heart. It's the lower chamber of the heart, that electrical activity that is the most important for sustaining life. So we're talking about what we call ventricular, bottom chamber, ventricular dysrhythmias, ventricular tachycardia, which is fast heart rhythm, or fibrillation, which is actually just fibrillating, just chaotically, just moving, but not pumping at all. And this is one of the leading causes of death in patients with heart failure and the United States in general, about 450,000 cases per year of sudden cardiac arrest. And, patients with heart failure have a 6 to 9 times greater likelihood of having a sudden cardiac arrest episode compared to the general population. So the ejection fraction, we're getting back to that, is really the key for prognosticating or indicating a higher or lesser risk of sudden cardiac arrest. So patients with systolic heart failure or weaker hearts actually have a greater risk for sudden cardiac arrest than do patients with normal heart function or diastolic heart failure. So I'll talk about devices like defibrillators a little bit more in a little bit, but an ejection fraction of less than or equal to 35% is a marker for a significantly high risk for sudden cardiac arrest, and that is the reason why we put pacemaker defibrillator devices in those patients. Sudden cardiac arrest can be terminated. It can be aborted in a patient who doesn't have a defibrillator device if CPR is administered very quickly, and if there's an external defibrillator handy within a few minutes. But it does have to be quite quick because it only takes just a few minutes before the patient's not able to be resuscitated. So most patients actually don't make it. It's very more than 90% of patients die from cardiac arrest who don't have defibrillators. And then we have the implantable defibrillator that has about a 90% success rate in terminating cardiac arrest. So how do we classify heart failure? It's medically classified into stages and severity of symptoms. So we have stages of heart disease and we have classes of heart failure symptoms that I'll talk about in a moment. The American College of Cardiology and the American Heart Association developed this staging system that categorizes patients between who have less severe versus more severe heart disease to emphasize the fact that this disease process is progressive. And then we have the New York Heart Association functional class that classifies symptoms of heart failure in patients with heart failure. And this classification system, both of these, help to guide our treatment patterns. So this slide shows you how we assess the severity of heart failure. On the left is the ACC AHA stages of heart failure. We have A, B, C, and D stages, and A is less severe, D is more severe. Basically, A represents patients who don't have structural heart disease or heart failure symptoms. They have risk factors for the development of heart failure. So they have smoking or high cholesterol, high blood pressure, et cetera, but no structural heart disease. And then we have stage B, which are patients who have structural heart disease, like their echocardiogram shows that their heart function is not normal, but they have not developed symptoms of heart failure. And then stage C are patients with structural heart disease who do have symptoms. Okay, so patients who have symptoms, I'll get to it in a moment. Maybe I should just move on to stage D, are patients who have advanced heart disease. Basically, these are patients who aren't going to live without a mechanical support or heart transplantation, stage D. So as it relates to the New York Heart Association functional class, we have 4 functional classes, and they go from the less severe to the more severely symptomatic patients. So functional class 1 are patients who have no symptoms. They can do activities of daily living, they can exercise, but they don't have any symptoms of heart failure. Class 2 patients have mild symptoms, so they have some symptoms with more than ordinary activity, they may get on the treadmill and then they feel symptomatic. They may go up over 2 or 3 flights of stairs and feel symptomatic. And stage 3 are patients with more moderate symptoms. Those are patients who have trouble with activities of daily living. They get out of the shower, they're short of breath, or they have just basically, it might not be symptoms that of shortness of breath that they get, but they're symptoms of heart failure with minimal activity. And those with functional class 4 symptoms are really limited and have symptoms even at rest oftentimes. So basically, patients with, who have stage A do not have symptoms, so by definition, they're functional class 1. In fact, we don't even call them functional class 1 because that implies heart failure, and they don't have heart failure. Stage B are patients who have structural heart disease, but they don't have symptoms. So they, by definition, have functional class 1 symptoms. Stage C are patients with symptoms. Now, this is where they can move from class to class with stage C. If you have a patient who has symptoms, they may start out at functional class 3, you put them on meds, and then they actually go to functional class 1 where they don't have symptoms, or they progress and they develop functional class 4 symptoms, and they can move in between. But the point is that once you're in class C, it's stage C, you don't move from there. You don't move back to stage B. So you have structural heart disease and more significant heart disease. And then functional or stage D patients often have class 3 and 4 symptoms. And so this slide shows you sort of the disease progression a little bit more in detail. So for instance, this is the stage. The stages are A, B, C, and D of heart failure. And stage A are patients with risk factors. So for instance, it may be obesity, diabetes, and hypertension. And then over time, if these risk factors aren't controlled, the patients may go on to develop some evidence of structural heart disease, like in the case of these, they may develop left ventricular hypertrophy, Or in the case of these patients with maybe hypertension, smoking, lipids, and diabetes, which we know are risk factors for coronary artery disease, they may actually have a heart attack. And so these would be sort of stage B patients without heart failure symptoms, but some structural heart disease. And then over time, just because of progression of disease or inadequate therapy, whatnot, we have this neurohormonal activation process that leads to remodeling of the heart, adverse remodeling of the heart, that then over time, maybe decades, leads to diastolic dysfunction in the case, for example, of somebody who has hypertrophy. The heart stiffens and it causes diastolic heart failure. Or in the case of this person who has a myocardial infarction, the heart may dilate and then they can develop systolic heart failure or a weak heart. And then as time goes by, they have this heart failure syndrome, and then in months, if not treated aggressively, the patients can pass away and go from stage C to D. So this slide shows you the approach to both prevention and treatment of heart failure as it relates to the stages of heart failure. And I'll get into it a little bit more in detail in a few minutes, but like I said, stage A, high risk but no structural disease. The therapy includes treating the hypertension, treating the lipid disorders, regular exercise, discouraging alcohol intake, smoking, and encouraging ACE inhibitors. And that's for patients who have certain risk factors like high blood pressure. And stage B are patients with structural heart disease. They're asymptomatic, no symptoms, and the therapy would include all of these under stage A, and including ACE inhibitors, and we'll talk about the medicines in a minute, so you'll understand a little bit more what they're about. Beta blockers and aldosterone antagonists in patients who have had a heart attack, who have reduced left ventricular systolic function, and then aldosterone antagonists in patients with diabetes and left ventricular dysfunction. And then for patients who have had a myocardial infarction and their left ventricular ejection fraction is reduced 40 days out from the heart attack, then a cardiac defibrillator device is recommended for those patients, even if they're asymptomatic, no symptoms. So in stage C, they're symptomatic or have been symptomatic, and the treatment then includes all of these measures. And by this time, the patients are symptomatic, so they're usually having some congestion, so we use diuretics to get rid of excess fluid to improve symptoms. And the ACE inhibitors, beta blockers, digitalis is one that we use for heart failure. I'll talk more about it in a minute. Sodium restriction is important, and then we have aldosterone antagonists in hydralazine and nitrates for African American patients, and I'll talk more about that in a moment. And then defibrillator devices, as well as in patients who qualify based on their electrocardiogram, what we call cardiac resynchronization therapy. That's a biventricular pacemaker to help with cardiac synchrony. And then stage D patients really are requiring mechanical assist devices and or heart transplantation. Or if they're not candidates for those, then it's very appropriate to discuss hospice care. So now we're going to talk a little bit more about the 4 classes of heart failure. These are the NYHA functional classes. As I mentioned, there's 1, 2, 3, and 4 that represent mild through severe heart failure for patients who have functional class 1 symptoms, no symptoms. They can perform ordinary activity without any symptoms. The treatments include the medications and self-care, and I'll go over self-care in a moment. Actions that you can take if you have functional class 1 heart failure or functional class 1 symptoms. Maybe you don't know if you have heart failure. Maybe it's advisable to ask your doctor if you have risk factors for heart failure. Do you have high blood pressure? Do you have diabetes? And are you smoking? What about alcohol use? How much alcohol is in your life? And there are other risk factors for the development of heart failure that you would want to know about so that you could modify those risk factors and hopefully prevent the development of heart failure. And then if you do have heart failure, you want to develop a treatment plan. Be involved in your care with your physician and help develop a treatment plan with your doctor. And if you have had a heart attack, but maybe you don't have heart failure or never have had heart failure symptoms, then you might want to know what your ejection fraction is, because that does somewhat stratify your risk for sudden cardiac death. And if you don't have a defibrillator device and your ejection fraction is low, it'd be good to know that and talk about that with your doctor. And the functional class 2 symptoms, like I mentioned, are mild symptoms. They may occasionally have some swelling in their legs from edema, fluid retention. Their activity tolerance is somewhat limited. Usually these patients can climb at least a couple of flights of stairs, walk several blocks without difficulty, and they don't have any symptoms at rest. Functional class 3, patients are comfortable at rest but have symptoms with mild activity, just like activities of daily living, like I mentioned, and they're comfortable at rest. And then functional class 4 patients, they basically can't do anything without having symptoms. And so if you have functional class 2 through 4 heart failure, your treatment or team approach, the treatment team should include an internist or general practitioner who can help to modify your risk factors, control the risk factors for heart disease, also to help monitor for fluid retention, to adjust diuretics, to help adjust any blood pressure medications if needed. And then, it's a good idea to have either a heart failure physician specialist or heart failure nurse specialist in addition to a cardiologist. So if you have a general cardiologist that specializes in heart failure, that's wonderful. But if not, if you have the opportunity to follow, especially with advanced heart failure, with a heart failure specialist team with a nurse practitioner, then that's probably optimal. Then it should include, for most patients, at least with functional class 3 or 4 symptoms, an electrophysiologist who can help monitor your heart failure device. And then treatments. Talk about self-care. I'll get to that a little bit more in detail in a minute. Medications, the heart devices, and surgery may all be included. And like I mentioned about having a heart failure specialist follow your care, not absolutely necessary, but if you are able to, that's probably a good thing. Talk with your doctor if you do have heart failure about your symptoms, if they change, if they get worse. It's better to apprise your doctor of these symptoms before they get too severe. It could land you in the hospital before anybody's able to make any changes to keep you out of the hospital. And then, if you're not on ACE inhibitors, beta blockers, the diuretics, digoxin, you might want to think about asking your doctor about that as well if you have heart failure. Want to know your ejection fraction. And if you don't have a device and you have heart failure, ask your doctor about heart failure devices. And for patients who have functional class 3 and 4 symptoms who don't respond to medical and device therapy, then they're often suitable candidates to consider heart transplantation or ventricular assist device. So the goals of treating heart failure may be obvious, but it's good to point it out. The goals are really to alleviate symptoms, to improve symptoms, alleviate them if at all possible completely, to improve exercise tolerance and exercise capacity and quality of life, to hopefully slow the disease progression and improve survival, and to prevent hospitalization. So you can take an active part in that by taking all of your medications, checking your weight daily. That's important, especially if you have had congestive heart failure. If you've retained fluid and you're on diuretics, it's extremely important to monitor your weight daily, because if you have a slow accumulation of fluid, you may get to a point where you don't notice it so much in terms of symptoms, but This slow accumulation can get to the point where augmenting or increasing your diuretics may not do the trick, and you could end up in the hospital. Or, the diuretics sometimes become ineffective when they're taken by mouth, orally, when you have a lot of congestion, a lot of fluid, because the fluid can build up in the lining of the gut and can actually reduce the absorption of the oral diuretics. And then you want to make healthy lifestyle changes. So it's imperative to stop smoking if you smoke, or alcohol is a direct myocardial toxin, so it directly reduces the function of the heart. So if you do have especially systolic heart failure, it's very important to avoid alcohol. And these are, some of the lifestyle changes that I already mentioned and why we implement them. The low sodium, low fat diet is extremely important. The sodium is really bad. It increases your blood pressure. It leads to accumulation of sodium and water, so that it worsens congestion and fluid retention, basically. And it fights against the effectiveness of the diuretics. So very important. I've had a number of patients with heart failure who ended up in the hospital after just going out to dinner one night at a restaurant. It's extremely important. And it's also important to lose weight, and not only because your risk factors are reduced, but also patients feel better. They walk further. The reduction in weight is good physiologically, and it also prevents a feedback loop that has normal or negative physiologic effects on the heart. And physical activity or regular exercise has been proven to improve exercise tolerance, and in some cases it has been shown to improve hard endpoints like the structure of the heart and function. So it's very important to exercise regularly, at least 3 to 5 times per week, 20 to 30 minutes in a graded exercise program, and based upon usually your maximum predicted heart rate. So usually it's recommended to start at 40 to 50% of your maximum predicted heart rate, and then gradually over the course of 4 to 6 weeks increase to about 70 to 80% of your maximum predicted heart rate. And I already mentioned alcohol and smoking. These are the medications that we use for heart failure. The ACE inhibitors, they're called angiotensin converting enzyme inhibitors. What they do is to vasodilate or relax the blood vessels in the body. That reduces the workload against which the heart has to pump. We also have angiotensin receptor blockers, which are usually used. They are very similar to the ACE inhibitors, but they're used in patients who can't tolerate the ACE inhibitors typically. The beta blockers are used to reduce the energy requirements of the heart and to blunt the effects of the negative effects of the neurohormonal axis, which is increased in heart failure and actually can cause this negative feedback loop on the heart. And then there's digoxin that actually increases the contractility of the heart and reduces hospitalizations. The diuretics I mentioned help to work through the kidney to get rid of excess sodium and water to decrease congestion, fluid retention, and improve symptoms. And then there's spironolactone and a similar agent called eplerenone. They're weak diuretics. They're potassium sparing, but they also inhibit or block the effects of this potent vasoconstrictor, angiotensin, which can lead to fibrosis in the heart and worsen heart failure that way. And then there are the hydralazine and nitrate combination, which in particular in African American patients, they lead to an improvement in symptoms and survival. They're also vasodilators. So this is a single slide sort of outlining how we manage heart failure. We want to control the volume, and we do that with diuretics. We want to slow the disease progression and reduce hospitalization and death. So we use proven therapies, ACE inhibitors and beta blockers. And then in African American patients, hydralazine and nitrates. And then we also use spironolactone or eplerenone in patients who have moderate or severe heart failure. Digoxin has been shown to reduce hospitalizations in patients with heart failure. So digoxin, and we'll go back to the donkey analogy. It's like the carrot being placed in front of the donkey. The donkey runs faster, is able to increase its activity. That's what digoxin does. Doesn't do anything really for the disease itself, doesn't reduce mortality or anything like that, but it does help to prevent hospitalizations. Let's talk about angiotensin converting enzyme inhibitors. This is the evidence that we have in a nutshell. These medicines are captopril, enalapril, lisinopril, fosinoprid. They're all the prils. And many of them have been studied in clinical trials of heart failure patients. Approximately 7,000 patients have been evaluated in these long-term studies that have been placebo-controlled clinical trials, and they've demonstrated time and again an improvement in heart function, symptoms, and clinical status, in addition to an impressive decrease in all-cause mortality by 20 to 25%, and a decrease in the risk of death and hospitalization by 30 to 35%. So very important drugs. So the diuretics and the ACE inhibitors are like reducing the number of weights or sacks on the cart. So it makes it easier for the donkey to perform. So these drugs decrease the workload on the heart and make it easier for the heart to pump. And then beta blockers they came along later than ACE inhibitors, and then were looked at in terms of efficacy and safety in heart failure patients, in addition to, on top of ACE inhibitors. And these drugs are like carvedilol, metoprolol, bisoprolol. Those are the heart failure beta blockers that have been shown to reduce the risk of death and hospitalization by 30 to 35%. They improve symptoms, they slow the progression of the disease, and they improve cardiac function as well. Beta blockers. They limit the speed of the donkey in order to save energy. So this is what they're negative inotropic agents. They blunt the sympathetic activation of the heart, and so that the heart requires less metabolic energy, and over time it leads to an improvement in the neurohormonal axis and improved cardiac function. Then we have spironolactone in heart failure. That's been demonstrated to reduce the risk of cardiac death and hospitalization by about 30%. In those patients on these drugs, they lead to potassium retention, so we have to monitor the potassium level carefully, because it can cause, if there's abnormal potassium, high potassium, it can lead to dysrhythmias that can be lethal. And then the other thing to note about them is that they can cause what we call gynecomastia, or breast enlargement, which has been seen in up to 10% of male patients that receive this drug. The other drug similar to this, the eplerenone, doesn't seem to cause the gynecomastia as much. So if somebody develops that side effect, we can always switch. And then the hydralazine and nitrate combination is now standard of care for patients with moderate to severe heart failure who are African American. There was a large, landmark trial that was done called the AHEF trial, or African American Heart Failure Trial, that demonstrated there was an impressive reduction of death or hospitalization by about 40% each. So, and improvement in symptoms. So, so they're definitely standard of care for African American patients. There was a study preceding this that didn't show any, in a general population of heart failure patients, didn't show as much of a reduction in mortality and heart failure hospitalization compared to ACE inhibitors. but in this population in particular, there was a significant benefit. We do use these medications as well in non-African American advanced heart failure patients. It's the same. They are vasodilators like the ACE inhibitors, and so they have certainly improved heart failure symptoms as well, just anecdotally. So this slide is an old picture showing a patient with severe heart failure in bed, and this lady at the bedside is clutching her chest and she's just struggling because there's nothing she can do for this patient. And we now have all these medicines, and the survival has improved significantly. The symptoms have improved significantly with heart failure, but I just want to point out we're still not quite there with the medicines, and we still have a large proportion of patients who have functional class 3 and 4 symptoms. 25% of patients with heart failure have class 3 symptoms, and 5% class 4. So more work to do. But how many pills can a single human being ingest? Have we reached this plateau effect of medical therapy? This slide shows you, at least on the right-hand side, many drugs that have been tested, evaluated in the treatment of heart failure that have not been found to be effective. And then there are many drugs that are currently being tested. But fortunately, we have now devices to treat heart failure as well. And that specifically being what we call cardiac resynchronization and ICDs, which are intracardiac defibrillators, or implantable cardiac defibrillators. These are the heart devices that we have. This one on the left is just a general pacemaker. It's used to treat arrhythmias, the slow heart rhythm abnormalities. Not necessarily heart failure in particular, but it treats a slow heart rhythm. And then we have the implantable defibrillator that is a pacemaker, so it treats slow rhythms. It also monitors for lethal fast rhythms and delivers either a shock or tries to pace the patient out of that rhythm. And so it prevents sudden cardiac death or sudden cardiac arrest, or treats sudden cardiac arrest, prevents sudden cardiac death. And then we have the heart failure pacemaker, which is basically a biventricular pacemaker. So it resynchronizes the heart so that the walls contract in a synchronized, more efficient manner. And this is what we call cardiac resynchronization pacemaker. And it also paces, of course, if the heart rate is slow. These days, for our heart failure patients with evidence of dyssynchrony who have heart failure, we have this great device now, and this is why it has a halo above it. It is a combination CRT device, cardiac resynchronization device, and defibrillator. So a device that we use very commonly in our advanced heart failure patients, at least. So this is an echocardiogram, still frame echocardiogram, showing a patient with a very large dilated left ventricle. This is the right ventricle here, triangular shaped. And it's outlined. I don't have any moving video on this, but in patients who have dyssynchrony like this patient does, and oftentimes those patients have a lot of conduction system disease. On the electrocardiogram, what we call QRS complex is wide. And what happens with this dyssynchrony is that it contributes to heart failure symptoms by reducing what we call the diastolic filling time, reducing the time that the heart has to fill. And it also weakens the overall contractility of the heart and the efficiency of the heart. And the mitral valve, which is the valve between the upper and lower chamber on the left side of the heart, between the left atrium and left ventricle, it actually, because of the dyssynchrony, can actually prolong leakage of the valve and contribute to increased volume of the left ventricle. And then the other thing is, what we see is this, that some of the walls actually contract beyond systole, so beyond the time where it should have stopped, and that's just inefficient. All of this leads to a decrease in what we call stroke volume, or decrease in the amount of blood that's ejected with each beat. So these resynchronization devices are pacemakers that are placed in 3 different positions, and basically they have a right atrial lead where the pacemaker goes into the right atrium, the right atrial appendage, and it paces there. And then it has another lead that goes into the right ventricular apex. So this is the right ventricle with the wall cut off. This is the right atrium. This is the tricuspid valve. This is the right ventricle. And here's a lead. This is the septum. That's the wall between the left ventricle and the right ventricle right here. So it goes right into the right ventricular apex at the septum. And then there's another lead that comes through, and this is what we call the coronary sinus. It's the vein that drains blood from the heart muscle itself. It drains into the right atrium. What they do is put this coronary sinus lead through the cardiac vein, coronary sinus, and out into a cardiac vein that lies along the left ventricle, the lateral wall of the left ventricle. And so what this does is it paces these, so it's biventricular. Both ventricles are paced at the same time, so it causes synchrony of contraction. And these devices have been shown to improve symptoms, improve exercise capacity, improve quality of life, reduce hospitalization, and reduce the risk of death even. Okay, so cardiac resynchronization increases the heart or donkey's heart efficiency. So the patient is able to exercise further, or exercise more, improve symptoms. So in summary, in terms of the cardiac resynchronization therapies, it's used for patients with moderate to severe heart failure symptoms with a left ventricular ejection fraction less than or equal to 35%, who are already on maximal medical therapy and who have evidence of ventricular dyssynchrony, which is typically a QRS duration of over 120 milliseconds. And in those patients, it's been found to be an adjunctive method for treating patients with heart failure, and it reduces all-cause mortality or all-cause hospitalization by 20%, and then 30% all-cause mortality or cardiovascular hospitalization by 30%, and it's basically 30 to 40% improvement in hospitalization and mortality. So talk a little bit about surgical indications for heart failure patients. There are relatively few. There are some patients who have an underlying cause of the heart failure who may have surgical disease. For instance, you have a patient who has functional class 3 or 4 symptoms, who has a very tight aortic valve. Well, that would be an indication for aortic valve surgery. So surgery is indicated if it can improve the overall heart failure. And that would include somebody who has evidence of significant blockages in the coronary arteries, in whom bypass surgery may be beneficial in terms of both symptoms and also improvement in blood flow and hopefully an improvement in heart function. And then for the patients who have severe heart failure, then we're talking about mechanical assist devices or heart transplantation. And this is the ventricular assist device system. It's basically made up of 3 parts. This is mechanical, basically artificial heart, if you will. It includes a pump, which is right here. Oftentimes they're implanted in the upper abdomen in a pocket outside of the abdominal cavity. And it includes this wearable, portable control system and also a power source. And it has a drive line that comes out of the skin, usually on the right upper abdominal wall. And they've made a lot of technological advances in the ventricular assist devices, And now we have what we call second generation ventricular assist devices that are available. The HeartMate 2 is a rotary electric constant flow. That means whereas the first generation devices were pulsatile devices, which actually pumped blood just like a heart would, but it was asynchronous to the heart, so it had nothing to do with was not in sync with the heart at all, but would pump. Now we have these second generation devices that are constant flow, so they're non-pulsatile, just constant flow devices. And this HeartMate 2 is smaller, it's quiet, it can be used longer term, at least over 2 years or longer sometimes. It can circulate up to 10 liters per minute. You know, a normal cardiac output is about 5 to 7 liters per minute, so it has the capacity to deliver a lot of flow. And it's been evaluated in over 250 patients in clinical trials. They've made some technological advances in the materials to reduce the infection rate, although infection always remains an issue and concern, complication. Now we have third generation continuous flow devices that have been developed, are being developed, and they're being, a number of them right now being studied in clinical trials. And those are, have made even more technological advances. They're smaller, they're even more quiet. And as we get more and more along in this, the devices are associated with fewer complications, fewer infectious risks, and clotting risks, and longer longevity. So right now it's, we're seeing a large increase in the, both the need for these devices, because the number, as you'll see in a moment, we'll talk about heart transplant. This is really for patients who have end-stage cardiac disease. Their longevity is expected to be relatively short, less than a year, 50% survival in 1 year typically, in whom their quality of life is poor, and this is all despite maximal medical therapy and device therapy, and who have either functional limitation with functional class 3 or 4 symptoms, or who have intractable chest pain from angina, from coronary artery disease, or who have had a lot of problems with ventricular dysrhythmias, so they keep getting shocked from their device, and we can't control the ventricular dysrhythmias. That those patients are at high risk of sudden death. And so those are the patients that we select for heart transplantation. And this slide shows you the number of transplants that have been done over the years. And as you can see, for this is 1990, this is 2008, so over the last couple decades, the number of transplants that have been done is stable. So we're not able to increase the donor pool, and yet we have many, many more patients with heart failure who need these advanced therapies. And so I think in the future we're going to rely more and more on these ventricular assist devices to treat our patients. This is a slide on survival of heart transplant and the surgical procedure. This is the surgery. Now, it's changed a little bit than these slides. I couldn't find the type of surgery that we do here now these days, but basically this is the right atrium right here, and this is a vent in here. This is the superior vena cava and the inferior vena cava. This is where blood flows from the body back to the heart, to the right atrium, and this is where the heart is sort of cut off, separated from the two chambers of the heart. Here's the donor heart here. This is part of the recipient right here, and this is a hole ready to sew from this SVC, IVC to this the recipient SVC and IVC. Right here is the left atrium. You can see the 4 pulmonary veins. These are veins draining from the lungs back to the left side of the heart. And here is the mitral valve. This is left atrial tissue from the donor heart, and it's sewed onto this left atrium here. And so here you can see after they've sewn the donor right atrium to the recipient right atrium, then you see here is the right ventricle. This is the pulmonary artery. right here is behind here. You can't see much of the left ventricle, but this is the left ventricle and aorta here. So at the end of it, what you have is the anastomosis, the SVC, IVC, so the right atrium anastomosis. And then this is the right ventricle with the pulmonary artery, where you have the donor pulmonary artery sewn to the recipient pulmonary artery, and here's the anastomosis with the donor to the recipient aorta. The survivals right now are approaching about 85 to 90% one-year survival, about 70 to 75% five-year survival, 50% 10-year survival, and about 15% 30-year survival. So we have some novel therapies that are currently being studied for heart failure. One type is the pericardial restraint device. These are meshes, they're metal meshes, very compliant. In this case, this is what we call HeartNet device that is made of a nitinol mesh that has a silicone outing, and it actually is inserted over the surface of the heart by a tiny little incision on the chest wall and placed over the heart to provide gentle compression of the heart, hopefully to reduce the tension of the wall from the dilation and to improve efficiency of the heart and to hopefully prevent remodeling, further remodeling and enlargement of the heart. Then we have, stem cells are being studied. That's a hot topic these days, stem cells. I think we have a long way to go. It's exciting to think about using these stem cells, both adult and embryonic stem cells, although embryonic stem cell development has been slowed due to ethical concerns right now, but they are studying the adult stem cells. And I just wouldn't rush out and try and find somebody ready to inject stem cells in a person at this time. I think we need to get a lot more data from our translational researchers and so forth before we start really using it as a viable treatment option for heart failure. And then we're also seeing some gene therapies. Some patients have heart failure that's associated with a genetic defect, that sometimes a deficiency, and it's perhaps going to be feasible one day that a deficient gene could be put into a vector and then injected into the patient or into the heart muscle directly, and that would be able to develop that gene and to circulate the gene to have an improvement in the patient's heart failure and cardiac structure and function. Or there are other, right now there is one hormone, at least one protein, that is being developed and used by a viral vector that's being studied that has to do with calcium handling in the heart muscle, and that is being studied clinically. So, there's some possibility there, but again, these are therapies that may be decades off. So in summary, the definition of heart failure is it's a clinical syndrome that's characterized by perfusion that's inadequate to meet the metabolic demands of the body because of an underlying impaired cardiac function. Heart failure is one of the fastest growing healthcare costs at $37 billion per year, and that number and that cost is estimated to increase as the years go by because of a number of factors, but especially because more people are surviving their heart attacks and so forth. They're living longer lives. And in the terms of the treatment of heart failure, lifestyle modification is extremely important. Exercise is important, weight loss. And then we have medical therapies that have been proven to reduce mortality and improve symptoms in patients with heart failure. They include ACE inhibitors, beta blockers, the spironolactone in patients who are African American, the hydralazine and nitrates. And now we have devices also, the cardiac resynchronization devices definitely have helped, not in everyone, about 70% of patients will have a response to cardiac resynchronization therapy. and it has been shown to improve symptoms and survival. And then the defibrillator devices, treat sudden death and improve survival. And then we have a number of heart failure therapies that are being investigated, and we're looking at better and better ventricular assist devices that are coming down the pike with improved survival, smaller, quieter, less complications. And so it's sort of an exciting time in heart failure right now. So that's it. Thank you. Does anybody have any questions? Sure. The question is, are there ventricular assist devices? No. The question is, are there ventricular assist devices that increase the heart rate relative to exercise?
Not increase the heart rate, but increase the flow.
Increase the flow relative to exercise. And the answer is no, they're not. Right now, they have not been adjustable based on activity. I think there is one that I read about that we don't have right now that has adjustable flow, is able to fluctuate the flow, let's put it that way. But the second generation devices that are constant flow are generally just set at one speed, once they find the optimal speed, and then they're left there unless there's a reason to change it. The first generation pulsatile devices, they would just eject blood when they filled. So if with activity, let's say there wasn't much of a change, I don't think, with activity, but if you with exercise, your body would fill the assist device faster, you would have an increase in the pump speed. But those devices were big, bulky devices, and not as well tolerated. The survival not as good either.
So not too much jogging.
Oh no, I would say that these patients feel so much better after these devices. They really are able to exercise and do whatever they want. It doesn't prevent your heart from working either. I mean, the patient's own heart continues to beat, and it can pump across the aortic valve and through the device also. So there is some augmentation with exercise in some people, depending on how severe their heart failure is. But they're oftentimes able to exercise. We did have one patient on the first generation, what we call pneumatic pulsatile device, who would jog even in the intensive care unit after the device was put in on a treadmill at an incline. So they can still exercise. Mm-hmm. The hydralazine and nitrates, they're vasodilators. Those are the ones in particular that are part of the standard therapy for heart failure in African Americans, in addition to all the other drugs.
Why is that required? What is the genetic difference?
Oh, the genetic difference we haven't sorted out. It was based on the AHEF trial, the African American Heart Failure Trial, and that was a dedicated study looking at that population, looking at the treatment of heart failure patients with hydralazine and nitrate combination, in addition to the ACE inhibitors and the diuretics, not beta blockers at that time. And that showed an improvement in heart failure symptoms and survival. That was very significant. The study before that in the general population did not show a significant benefit, but when they looked particularly at African Americans, they saw a significant benefit in that population. So that's what led to the other AHEF trial. We have known that ACE inhibitors in particular are less effective in African American patients at reducing blood pressure, and so that may have at least something to do with why the patients who were let me put that a different way. The ACE inhibitors were more effective in treating patients with heart failure than the hydralazine nitrate combination when you looked at the the general population. So we haven't looked at just Caucasian people, but when you mix them together, it was a null. I think there's something to that, but I don't know that they'll do another study specifically looking at other races. The point was that there may be a lot of issues with compliance if patients who have heart failure are on the Ornish program. So I have to admit that I don't know the details of the Ornish program, but so I don't know if you have specific knowledge. What in particular are you talking about in terms of compliance, maybe? That might.
The whole diet is different. I mean, if you have trouble keeping people on a low sodium diet, you're going to have problems keeping them on, it's almost a vegetarian, very restricted.
Yeah. Well, you know, my whole plan with regard to a diet is that I just keep it pretty simple in terms of heart failure. It's really sodium that is the main issue with heart failure. So as long as the diet is a low sodium diet, and in patients who have ischemic heart disease or coronary artery disease, then they should be on a low fat diet just to treat the coronary disease. In patients who are diabetic, in order to treat their diabetes, they should be on a diabetic diet. And in whatever kind of combination they could come up with to achieve those goals for those risk factors, it doesn't matter to me. And as long as they're maintaining a lower weight, they're not gaining weight, and hopefully if they're overweight, that they're losing weight and that they're able to exercise. So, two questions. First is, can I define volume overload more specifically? And the second question is about the surgical risks with implanting a pacemaker or defibrillator device. So the first question, volume overload, we use that a lot. It really means intravascular volume overload. So with heart failure, what happens is there's crosstalk between the heart and the kidneys. So the heart is not able to pump blood efficiently to the kidneys, and the kidney responds. It notices that lack of blood flow, and then it starts holding on to sodium and water, sodium fluid, to increase blood volume, to increase perfusion to the kidney. But this is a cycle that's damaging for the whole body and causes more symptoms, and then what we call third spacing. It just causes fluid retention into the lungs and swelling in the legs and so forth. So, so that increase in intravascular blood volume is volume overload. And we can look at that, and specifically the heart failure doctors, the cardiologists in general, will look at the vein in the neck, the jugular vein. And normally the pressure on the right side of the heart during what we call diastole, so when it's relaxed, the pressure on the right side is very low, like 0 to 5 millimeters of mercury. So basically the blood that's returning from your head and going into the heart, it drains into the heart, and it doesn't distend. It has very low pressure. So the vein isn't normally distended at all. It's flat. So if the pressure rises because of fluid retention and heart failure, you can see the distension of the vein coming up higher and higher and higher on the neck. And so that's what we call volume overload. It's usually associated with some edema, although not everyone has edema. Some people don't have, this is a marker of, that's the right side of the heart. Some people just have left-sided heart failure, and they have evidence of, or symptoms of fluid in the lungs. There are some people who don't have heart failure who have edema, and it's not from the heart, it's from medicines like calcium channel blockers or some other diseases that are associated with that. So, but specifically volume overload, we're talking about congestion from heart failure. And then in terms of the placement of the defibrillator CRT devices, it's actually not a very complex surgery. It's a very minor surgery. It involves just an incision, maybe 4 centimeters, and they just dissect a little tissue plane. They access the vein that goes right underneath the clavicle, and they feed the wires. They don't open up. They feed the wires into the heart under fluoroscopy or continuous X-ray. And then once they get them in place, they attach them to the generator, slide the generator into the little pocket that they made, and sew it up. And so it actually doesn't damage the heart at all. You're just placing leads inside the heart.
They're not secure to the walls.
Well, they actually screw it in a little bit. Yeah, so that it stays. Go ahead. So the resynchronization currently is for pretty symptomatic heart failure patients. So they're not usually the athletes or anything. They're usually, if they are were athletes and then they develop moderate to severe symptoms from heart failure, then they would be a candidate for that. But in the absence of heart failure symptoms, the resynchronization hasn't, in fact, they're looking at patients who don't have many symptoms but have some dysynchrony, looking at that population. But we don't have any data right now showing any benefit in that population of patients. The defibrillator devices, though, if you're identifying a patient who has hypertrophic cardiomyopathy, which is one of the significant causes of sudden death in athletes, then if you're able to identify a person with that disease, defibrillator device would sometimes be indicated in that patient, although they would be advised normally not to compete. The question is, what's the difference between silent heart attack and not a silent heart attack, and is there a difference in treatment? And many heart attacks are silent, about 40, sometimes up to 50% of heart attacks, and heart attacks, that is, the definition of a heart attack is when the patient has some, usually if it's not a silent, symptoms usually that go along with inadequate blood flow to the heart. So that angina, some sort of angina symptom signifying the heart's not getting enough blood flow. Sometimes it's chest discomfort, sometimes jaw discomfort, arm discomfort, shortness of breath, sweating, nausea. Some people don't get any of those symptoms, and then they have a heart attack and it's silent, and it may show up on an EKG years later or on some other cardiac testing years later. No, the person never had any symptoms, but then they showed signs of scar, so dead muscle from a heart attack. So you can either have a silent or not or a clinical heart attack is what we would call it. And you would treat them in terms of the management, chronic management of heart failure or of coronary disease the same way. And that would include, beta blockers, ACE inhibitors, statin, aspirin. And then if there's ventricular dysfunction, like I was talking about, that would be stage B. That person would have stage B heart disease and would be on, go through that algorithm with the lifestyle changes and all the risk factor modification and all of that. If there was, that's a beta blocker, ACE inhibitor, statin, aspirin usually. Yeah. That's a good question. The question is, in terms of diuretics, how do you know when to increase the diuretics? How do you adjust the diuretics? And basically, at least initially, the cardiologist or the physician would try and find the right dose for you. Let's say you came into the hospital and then were discharged, or you came into the clinic and on exam they could tell you had some congestion or fluid overload. Then they would increase the diuretics. You would not be expected, and nor would we want you to adjust the diuretics on your own, because we would want to see you back to see what the effects were of that. Always keeping a record of your daily weight is extremely important. But let's say, so that along with regular visits to check and adjust the diuretics until you get a stable dose are very important. Then once you have a stable dose, then that weight that you have at that time would be your dry weight, and that would be the weight upon which you would compare every day from there on. And typically, if you gain more than 3 or 5 pounds from your baseline weight, then that would trigger a call to the office and say, hey, you know, my weight's up. And then as you get out further in terms of your education about it, sometimes the patients are very knowledgeable. They understand when they're fluid overloaded, you know, and then when their weight is up. So they, with our discussion, our treatment plan together would be that they would take an extra diuretic if they gain, you know, more than X number of pounds, or if they notice a little edema in their legs. So it's adjusted based on the individual and couldn't be applied to a whole population. It is different for everyone, but that's about, generally speaking, how we would manage somebody. Sure. So in terms of side effects, the ACE inhibitors, the most common side effect would be a cough, a dry cough, a nagging dry cough. And if that occurs, then we would switch. That would be one reason why we would switch to an angiotensin receptor blocker. So a very similar drug, just a different class. The other side effects are lip swelling or eye swelling, angioedema. That would be an allergy, and we would stop that. Then the rest of the side, it's generally well tolerated, those ACE inhibitors from there. Occasional headaches, some gastric, you know, abdominal upset, but otherwise pretty well tolerated. It leads to retention of potassium, so we have to monitor for potassium levels and make sure that they don't go up to a dangerous level. And then in terms of the beta blockers, fatigue would be a side effect, and then erectile dysfunction is a possibility. Any of the drugs, all these heart failure drugs can lower the blood pressure, so dizziness is a potential for any one of them. And then we have the spironolactone, which can also increase the potassium levels. It's generally well tolerated. Dizziness, like I said, is in common with all of them, but it's generally well tolerated. And then digoxin, it doesn't usually cause any symptoms unless there's toxicity. And toxicity can cause visual symptoms or gastrointestinal upset, nausea, vomiting, shaking. It can cause arrhythmias if the levels are too high. We usually monitor the levels of the digoxin in the blood. And the hydralazine and nitrates, those can cause headaches. They're vasodilators. They can cause, again, low blood pressure, but otherwise pretty well tolerated. Some of the vasodilators can cause a little bit of edema, but not usually. Okay, well, thank you very much. Thank you.